I'm Doris Barwich, and I'm the Porgram Medical Director for End-of-Life Care in Fraser Health. And in that role, I've been involved with advanced care planning initiatives at the local, provincial, and national level since 2004. So an advanced directive is my durable intent, usually, to refuse a certain kind of health care. So, for instance, I do not want to be resuscitated. I do not want to be ventilated. I do not want to be put on breathing machines. I don't want kidney dialysis. I don't want blood transfusions for religious or other reasons. So there are some of these healthcare treatments that people have a durable intent to refuse, and if they document that in an advance directive, that absolutely needs to be followed. It's about autonomy. The person has the right to say what happens to their own body. And so as healthcare providers, we need to look for evidence that a person has said no, and then no means no. So the role of a substitute decision maker is to speak for the person when that person can no longer speak for themselves. So let's say a person becomes incapable through a severe motor vehicle accident or a trauma, or they have dementia and progressively are unable to communicate effectively, to understand what the decision is and what its implications are. Then a substitute decision maker would be someone who would speak for that person. And a good question for substitute decision makers is, if Jack was here, what would Jack say we should do? When healthcare providers say to substitutes, what do you want us to do? It reinforces this ambiguity and this ambivalence about, well, I'd like him to be fully treated, but my dad's been quite clear that he doesn't want anything more to be done. So often there is this ambivalence, and that's often what makes decision making so difficult. Because really the role of a substitute decision maker is to speak for the person. But also we need to acknowledge that they may have their own perspectives and lots of emotions in the crisis and other things that play into that. The most important thing about advanced care planning is conversations. So conversations that help people understand, have time to reflect on and discuss their healthcare decisions in a way that reflects their values, their beliefs, and their preferences. So physicians are key in terms of providing information about the illness that a person may be suffering from. And a physician needs to demonstrate that no matter what choice a person makes, we will do the best we can for them. We will always care for them in a way that honors them and that respects the quality of their life. But we need to know what they want so that we can provide the care that's most appropriate for them. Ideally, when you're faced with a healthcare decision, you go to the person directly to ask for consent. This is what we found, this is what we want to do. If you give them time to understand the implications and then make a decision, yes, I'll go ahead with that surgery, or no, I don't think so. If that person's not able to speak to you, then a number of options exist, and there's lists prescribed by law in terms of who you need to speak to get consent. So the first would be someone who's been incapable most of their life, may have a guardian or a committee of persons. Or they may have appointed a representative. So you and I may make an agreement that my husband will speak for me if I cannot, or my best friend or my partner will speak for me if I'm not able to do that. And that may be documented in a representative agreement. A physician needs to ask for a copy of that because different representative agreements have different scope for the decision maker. And if there's none of those people appointed, then there's a list that the healthcare provider needs to follow in terms of a spouse, adult children, etc., in terms of who may make decisions for you. What we're suggesting physicians think about is when you first come into contact with someone that's not known to you, let's say you're an emergency room physician, that you ask about evidence of advanced care planning. So the way we've done that is we've created an Anomic called Speak. So you ask about S, is there a substitute decision maker, someone that you've appointed to speak for you, who knows what you would want? Do you have preferences about your care? Do you have fears or concerns or things that I need to understand about you so that I can align the care more to your needs? Are there expressed wishes such as a My Voice document or a living will that has a record of what your preferences are? Do you have an advance directive, the A? And is there anything else you would want to know from me to make the decisions that you need, and a commitment to that person that as new medical information becomes available, we will talk to you, we will inform you, and we will continue to explore your wishes and preferences as more information becomes available about your care. I think that healthcare for a long time has been moving in a direction of more partnership between patients and healthcare providers, and I think this is an important step of really helping people come to the table as informed consumers and to make the decisions that are right for them. Certainly with the baby boomer generation, there's lots of evidence that we will want to be active participants in our care, and then we may have very particular wishes, and this law provides the tools and the resources for people to really have options available to express that in a number of ways that then can inform healthcare decision making.